Welcome back everyone to the third part series of the anesthesia overview. Today we are going to discuss inhalational anesthetic induction agents and how they work. This video presentation is purely for educational purposes, targeting to MRCS candidates, and is a collaborative work with the Association of Laparoscopic Surgeons of Great Britain and Ireland. These are the learning objectives that we aim to cover today. Overall, intravenous induction is simpler in terms of technicality, but it has more risk of hypoxia. Some inhalational agents are bound to cause airway irritation, which we will come to that later on. In clinical practice, IV induction is preferred unless clinically indicated or it's by the patient's preference. It is important to know that oxygen supplementation post-anesthesia induction is different from inhalational anesthetic induction. Before us jumping into more detail about inhalational anesthetics, let's take a moment to understand the concept of minimal alveolar concentration. By definition, it is the concentration of inhaled anesthetics vapor in the alveoli of the lungs of 50% of the population by using immobility as a benchmark in response to surgical stimulus. This qualitative endpoint is then used as a standard of measurement of potency of an inhaled anesthetic agent. Preferably a volatile liquid. Secondly, it permits concurrent administration of oxygen-rich air or an Antonox. It should also have high tolerability, low minimal alveolar concentration, rapid onset and offset, minimal post-administration or systemic side effects, and lastly, cost effectiveness. Inhalational anesthetic agents are indicated when the aim is to avoid IV access, such as in the pediatric population, patients with needle phobia, and lastly, in the case of peripheral shutdown. Secondly, it is used to maintain airway patency and spontaneous ventilation in ventilation scenarios like an anticipated difficult intubation, where manual ventilation is required, or in the case of inhaled foreign body, where eventually cause difficult intubation. The image below shows a bronchopleural fistula, which is a sinus tract between the mainstem, lobar or segmental bronchus to the pleural space. It is a potential catastrophic complication following pneumonectomy or other pulmonary resection. The main objective of an inhalational induction in the case of bronchopleural fistula is to maintain good oxygenation and ventilation while avoiding tension pneumothorax, as well as avoid soiling of the good lung from aspiration. We then now look at what it takes to perform a good inhalational induction. First thing first, as with anything in medicine, communication is key. This is to ensure the whole process to be as pleasant and as it can be, and patients to understand what they are about to go through exactly. Some anesthetists uses anti-sialagogue like atropine prior to the procedure to reduce airway irritation. Secondly, routine monitoring, close-fitting mask facilitates safe and speedy induction, and must remember to always have a backup plan for anticipated difficult airways. Oftentimes, sevoflurane is the agent of choice, with reasons which we will discuss later. The next slide shows the types of inhalation agents that we are about to discuss today. First up, we have nitrous oxide, which is found as Antonox in the clinical setting in places like labor ward or the A&E department during a fracture or dislocation reduction. Antonox is safe to use in combination with sevoflurane as an inhalational induction, and it is rapid with short-term side effects such as euphoria, depersonalization, derealization, nausea, vomiting, and dizziness are common. If used alone, it has low potency, hence it is not suitable for surgical anesthesia. The next diagram shows a deep diver with a no Antonox bracelet. So why and when would you need such a bracelet? So let's say if you had unfortunately been in a car accident on your way home from a dive, British paramedics could give you Antonox gas as a pain reliever. The problem with that, Antonox is a mixture of 50% of oxygen and 50% of nitrous oxide, which could trigger decompression sickness because it heightens the amount of inert gas in a diver, particularly if he or she has dove within the past 24 hours. Nitrogen bubbles form in the tissues of the body. It is suffered particularly by the divers, who often call it the bends, and this can cause pain in the muscles and joints, muscle cramps, numbness, nausea, and paralysis. And if you're unconscious after the accident, it will be very helpful to be wearing something like this on your body that warns the paramedics against administering such a gas. Next up, we have sevoflurane in this presentation. Sevoflurane is a well-tolerated halogenated ether as an induction agent of choice compared to isoflurane. As mentioned previously, safe combination of sevoflurane and Antonox improves tolerance and speeds up the onset of anesthesia. One key to note is that in the case of suspecting or anticipated airway obstruction, 100% oxygen is preferred with sevoflurane over Antonox to ensure maximum oxygenation and ventilation of the lungs. Thirdly, we have desflurane, which is also a well-tolerated halogenated ether, though more irritated than sevoflurane, hence more suitably used as a maintenance rather than an induction agent. When compared to desflurane, sevoflurane has an overall better cardiovascular profile, which causes less cardiopulmonary depression than desflurane. As with any other fluranes, it has a risk profile of hepatotoxicity. Lastly, with halothane as the last inhalation induction agent on the list today. It is no longer used in the UK and commonly used in the developing countries due to its cost effectiveness. Halothane is colorless and pleasant smelling with little analgesic effect, but it decreases sympathetic and vagal outflows that plays a role in peripheral homeostatic regulation. An increased sensitivity of the heart to catecholamines is a recognized risk during acute human exposure to halogenated hydrocarbons. The halothane was first introduced as an anesthetic agent in the 1950s and was considered a revolutionary agent in the field of anesthesia. Soon after, halothane-induced hepatitis became a concern, leading to the development of a subsequent less toxic gases that can induce a lower incidence of side effects. There are two types of halothane-related hepatotoxicity that have been described. The type 1 is the first type that presents as mild hepatitis post-halothane exposure associated with elevated transaminase levels, and they are self-limiting. The type 2 is the more severe type of hepatotoxicity, which is associated with acute fatal liver failure, and it is fatal in most of the cases. The hepatotoxicity is most likely to be immunological related based on the limited evidence. This is a brief summary of the key points for each type of inhalation anesthetic agents discussed. Last but not least, let's take a look at malignant hyperthermia, which is a potentially lethal hypermetabolic response triggered by inhalational anesthetics or susamectonium. Malignant hyperthermia is an autosomal dominant RYR1 gene mutation. There is no phenotypic changes that could be recognized, hence it is impossible to diagnose in the first place. Definitive genetic diagnosis is required after an acute episode that has resolved, including testing the first-degree relatives for malignant hyperthermia. It may also form part of the autopsy investigation if malignant hyperthermia is the cause of death following exposure to the anesthetic agents. Malignant hyperthermia is susceptible to people who may experience discomfort during exercising in the heat with uncommon complaints of muscle pain. Clinical presentation of malignant hyperthermia includes an unexpected increased end-tidal carbon dioxide production and oxygen consumption during induction of anesthesia due to the body's sudden increase in metabolic rate. Muscle rigidity, tachycardia, hyperthermia, and metabolic acidosis are some of the features that suggest malignant hyperthermia after the patient has received inhalational anesthetics or a depolarizing muscle relaxant. The immediate management of malignant hyperthermia includes: first, stop the ongoing agent and call for help. Hyperventilate the patient with 100% oxygen and maintain anesthesia by intravenous propofol infusion. The proposed surgery has to be abandoned and intravenous dantrolene plus active cooling has to be initiated. And lastly, check and treat any biochemical insult such as rhabdomyolysis, which can be shown by markedly raised creatinine kinase causing acute kidney injury or failure and subsequently cause hyperkalemia and disseminated intravascular coagulopathy or DIC, which presents with deranged coagulation profile with a raised D-dimer as a sequelae from malignant hyperthermia. That's all for today. Thank you very much, and on to the next one.